Good afternoon, ladies and gentlemen. I am Dr. Rahul Mandlik. Would like to welcome you all on behalf of Shalina Healthcare. Today, we are going to discuss about one of the most common health element, that is about the pain. So, which is frequently present as a reason of either disease or an injury. However, it is not merely an accompanying symptom, but rather it is a separate condition in its own right. Today, our expert speaker, Dr. Sai Priya Tiwari, is going to share expert guidance on pain and its management, particularly considering primary care setting in the view. So, audience, today's session is going to be very interesting, where Madam is going to talk about right from what is pain, its different categories, the science behind how pain takes place, and why we feel pain, different tools and techniques to detect pain, and very comprehensive approach for its management. So stay tuned. Before to that, briefly about us. Today, Shalina Healthcare is one of the leading pharmaceutical companies in Sub-Sahara Africa. From last 40 years, it has been our mission of making quality and affordable medicines and to make them available across the region. We ensure quality of our products by manufacturing them in WHO approved facilities. We have partnered with several African as well as international professional bodies to fulfill your educational needs. Also, we are working with many institutions, universities, and NGOs to roll out many patient centric programs. Today's webinar is brought to you by Shalina Academy, which is an initiative from Shalina Healthcare. Through this platform, we keep on rolling out online as well as offline continuing medical, pharmacy, as well as nursing educational programs. With this, let me introduce our today's speaker, Dr. Saipriya Tiwari. Madam is a pain consultant at Manipal Hospital, New Delhi, India. She is a fellow of Interventional Pain Practice, that is FIPP, from World Institute of Pain, USA. Ma'am has got postdoctoral certificate course in pain management, and she is a certified EPIC trainer, that is education in palliative and end of life care. Dr. Tiwari has also completed certificate course in Essentials of Palliative Care, which is from Indian Association of Palliative Care. And Dr. Tiwari has got fellowship on regional anesthesia and pain management at Ganga Hospital, Coimbatore, India. Currently, Madam is a reviewer of two medical journals, and she has published many articles in reputed international as well as index journals. Thank, welcome you, ma'am.
Thank you. Thank you for that warm welcome.
Yeah. So before I hand it over to Dr. Tiwari, I would like to inform you that the flow of today's program is that ma'am will present her session. Followed by that, we'll have a Q&A session where I will be taking questions on behalf of you. And so please feel free to post all your questions in the box provided on the right side, and you can even post your feedback about this session and some suggestions for the future webinars. Thank you so much. Over to you, ma'am.
All right. So, good evening, everyone. It's a pleasure to be here. And thank you, Dr. Rahul, for that kind introduction. And I'm really excited to be speaking to such a valuable and large audience today. There are so many of us who are working in healthcare, and so many of us who are seeing pain on an almost daily basis. I've been given an opportunity to talk on one of my favorite topics, that is, of course, pain management for primary care providers. So let's start. So, as we all know, as healthcare providers, that uh, pain in anybody's clinic, everybody who's here in the audience today, in everybody's clinic, pain is one of the most common symptoms that patients present with. And pain is a very different feeling for different people. It is described by International Association for the Study of Pain as an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. So this means that if a person is in pain, he may or may not be suffering from tissue damage, but he can still experience that subjective sensation. So, as we say that although the mind over matter may be an exaggeration, but still, uh, different people feel the same kind of pain differently because nociception is different and the actual total perception of pain is different. But having said that, when we are studying about pain and management of pain, we are taught a very basic thing that, if a patient says he has pain, full stop. You will not judge by yourself whether or not a patient is in pain. If an individual is saying that I'm having pain, then you have to believe that individual. It cannot be it cannot be objectified by any other manner. So, starting with that, if a patient is saying pain, he has pain, and the fact that he has pain is that means that you have to treat it. So, that is the approach that we should be having towards these patients. Uh, Pain itself does have a survival value or a biological significance. It means that why why do we have pain? So sometimes pain can be useful. What kind of pain is useful? It is useful if it indicates that something is wrong with the body. For example, if somebody is having some abdominal pain and it might indicate that there is underlying appendicitis, then that is a useful pain. That has a survival value. It is a warning sign which the body is giving to us to understand that there's something wrong and you need to take care of this. Okay, so that is when the subjective description of pain, it is helping in the medical diagnosis of a disease or an injury. So in this kind of a situation, although this pain is unpleasant, but in the long run it is a warning sign. It is helping us to identify something bigger and act early to treat that. So that is the survival value of pain, but this is the only good pain. Um, Pain for the longest period of time has now been labeled as the fifth vital sign. So, as we know, whenever a patient comes to us, we always check the vital signs of the patients. That's one of the most basic things that we do. So, the vital signs include temperature, pulse, respiratory rate, blood pressure, and as the fifth vital sign, pain. As early as 1995, Dr. James Campbell proposed this uh, in the presidential address to the American Pain Society, and it has been accepted and validated as the fifth vital sign. So it is routinely used, it is routinely monitored in a lot of places as the fifth vital sign. That's how important it is, that's how vital it is for us to identify it and recognize it early. Now, if you talk about the global impact of pain, I'm sure everybody sitting over here, everybody in the audience would know somebody in their family or in their clinic or in their work staff or in their neighborhood who has pain. So all of us know people who have pain. So it is not a surprising figure to note that globally 1 in 5 adults suffer from pain and 1 in 10 adults are newly diagnosed with chronic pain. So that is the kind of that is the significance, that is the quantity of pain that the world is suffering from. And in sub-Saharan Africa, data says that 1 in 2 persons suffer from low back pain and 1 in 5 African adults have chronic pain. This is very similar to the data in the rest of the world, that pain is literally a pandemic now. Now, if we talk about categories of pain, uh, it can be classified based on various uh, uh, things like classifications like duration, location, intensity, and etiology. So first, if we talk about the duration of pain, the pain can be acute or chronic. So typically, acute pain is something that lasts for a period of less than 3 months. A chronic pain is any pain which is going on for longer than 3 months. So chronic pain examples could include, it could be a non-cancerous pain, or it could be cancer pain, or it could be even episodic, but it has been coming in episodes for a very long time, for more than 3 months. Based on location, of course, in the whole human body from head to toe, it can be anywhere. It can be a headache, it can be a back pain, it can be a joint pain, it can be a stomach or visceral pain, it can be a cardiac pain. So location, on the basis of location also it can be classified. On the basis of intensity, of course, whenever we are asking a patient, how much pain do you have? Is it mild pain? Is it moderate pain? Or is it absolutely severe, unbearable pain? So that's how we classify based on intensity, based on etiology. Now, what kind of etiology? We will try to identify why the patient is having this pain. Is it a nociceptive pain, which is coming from a somatic or visceral area, or whether it is a neuropathic pain? Neuropathic is when there are some nerve pain related features. So, typically, if a patient has neuropathic pain, he will describe sensations like a tingling or a numbness, or maybe some people say we feel that ants are crawling in that distribution. Some people say that there is a burning sensation, or typically, for example, in radicular pain, people can say that we experience electric shocks going into our leg or our arm if it is a radicular pain. So all these kinds of pain come under the category of neuropathic pain. This is a more detailed slide on the categories of pain. So in this, if you see on top, category 1 has been described as transient pain, acute pain, or chronic pain. So like we said, if you remember, we discussed in the definition by IASP, pain can be present in the presence of tissue damage or in the presence of potential tissue damage when actual damage has not happened. So, for example, transient pain can happen even when there is no tissue damage. Acute pain usually happens with tissue injury, and chronic or persistent pain can happen because of either tissue injury or because of nerve damage. Now, coming to the second category, if you see again, so they have the color coding is such that the blue pain is physiological pain and the orange pain is all pathological pain. So, what are they calling physiological pain? Physiological pain is helpful pain. Okay, like we discussed earlier, the pain that helps in identifying something bigger. So this kind of physiological pain can either be physiological, which is happening in response to a noxious stimulus because of stimulation of the peripheral nerves. It has a protective function to the body. So for example, if you touch a pin, the pain will immediately tell you to move your hand away. Or if you touch a hot plate, the pain will immediately tell you to move your hand away. So it is protecting the body. Another is nociceptive. It is again in response to noxious stimulus because of stimulation of the peripheral nervous system. It has a protective function, for example, a trauma. So if, for example, if you have trauma in your arm, the body will splint or you will not move it. Example. Now, all other kinds of pains are pathological pains, whether they are inflammatory, neuropathic, or cancer pains. They are happening because of some or the other kind of damage. The pain is happening at the peripheral level as well as the central level, as you can see in all three. Only this inflammatory pain, for example, in arthritis or post-operative, this kind of pain is helping in healing or repair. The other two are purely pathological. They have absolutely they're not assisting the body in any way. They are just decreasing the quality of life of the individuals who are suffering from this pain. So again, discussing acute versus chronic pain. So I think by now we have established that acute pains or pains for a short duration may sometimes be helpful pains. But chronic pains are never helpful pains. Chronic pains are the ones that are ongoing and lasting longer, lasting more than 3 months, usually ranging from mild to severe, and they have absolutely no positive impact on a patient's life. Now, coming to common pain conditions that we routinely see in our clinics. So, as has been said previously also, pain is probably one of the most common reasons that an individual seeks medical attention. It can be because of injury, it can be because of surgery, it can be period pain, menstrual pain, it can be arthritis related pain, it can be toothache, headache. So all these ones are usually the ones which usually last for a shorter period of time, although arthritis can be a chronic situation also. And then chronic pains could include back pain, like I said, arthritis, nerve related pain, fibromyalgia, cancer pain, all these come under the longer duration pains. Now, there was a study, Pain as a Global Public Health Priority, which states that 20% of adults suffer from pain globally and 10% are diagnosed with chronic pain each year. So, earlier also we discussed this, and there's absolutely, we have, I think, kind of established that globally it is a major problem and it is leading to a lot of consequences in terms of depreciating the quality of health of an individual, the quality of life of an individual, and thereby their participation as an individual in their families, in their workplaces, and so on. Now, this is a very interesting slide because this is very important, especially when we talk about cancer pain. But it is true for all kinds of pain that pain is a very multidimensional symptom. So, as you can see, this circle in the center, there are 4 dimensions of pain. There is physical pain. So, what is physical pain? Physical pain is that if somebody says, "Okay, doctor, I injured my hand and I have pain over here," that is the physical pain. But that is just the tip of the iceberg, or that physical pain that the patient is describing is just 1/4 of the total problem that he has. Why? Because, uh, or that physical pain, for example, could be cancer related. So the patient is saying, I have oral cancer, I have pain in my jaw and my neck. So that is the physical component of pain. What is happening as a consequence of that physical pain? As a consequence of that physical pain, the patient is scared, he's afraid, he may be frustrated, he may be depressed. He may feel, why I'm not able to participate in work. So he may have some loss of hope. So that is what is the psychological pain of the patient. Then there's something called as spiritual pain. What is spiritual pain? People who are spiritually inclined would understand this better. But if a patient is in pain, or if an individual is in pain, he might feel like, why is why has God done this to me? Why not somebody else? So it leads to anger with God. It leads to a sensation of feeling of loss of meaning, loss of faith, a loss of spiritual health in general. So this is the spiritual component of pain. And the fourth one is, of course, social. Why social? Because if a patient is in pain, he cannot go and sit with his loved ones. He doesn't want to. If a patient is having headache, he would prefer to sit in a room alone and not participate in any, for example, a birthday party. Or if a patient is in pain, they cannot go to their offices. They cannot work. They might lose their job because of it. Because of that, they might lose their social status. If they are out of job, they can even have financial challenges. So this is a very important slide, because whenever we are talking about pain, particularly when we are talking about cancer pain and chronic pain, we always remember that there are actually these 4 components of pain that need to be looked into. But typically patients will not tell you all of them, because there is a barrier when generally all over the world, that when you are walking in as a patient to a doctor, you tend to tell only your physical problem. So we as healthcare providers should always remember that if a patient is telling us something, he is sharing only his physical problem with us, but it is up to us to recognize and acknowledge and identify the other 3 dimensions of pain. Only then we will be able to manage the pain in totality. uh, Moving forward, okay, a bit about anatomy and physiology of pain. So, quite honestly speaking, anatomy and physiology of pain is quite a long topic, and it takes quite a long time to read it and understand it. But I'm happy that this diagram kind of tells in brief about the pain pathways which are there, because of which we are feeling the pain. So, as you can see, there are 4 important steps in from the time that a pain starts till the point that it is perceived by an individual. It is perceived in 4 steps. So the step number 1 is transduction, whereby a painful stimulus is getting converted into a painful response. Second is transmission, as to how it is going to get carried. For example, there is an injury. How the sensation is going to get carried to the brain. This is the number two, which is transmission. The transmission has reached the brain. The third part is perception. How has the brain perceived the pain? And the fourth, very important component of the pain pathway is modulation, because as the information is going from the periphery to the brain, it is modified at various levels by a number of neurotransmitters. So it's similar to any kind of information which is going from point A to point B. In between, it is often twisted. The facts can get twisted. The facts can get modified. Some might get exaggerated. Some might get totally drowned. And then that is how the information reaches point B. So this modulation has a big role to play whenever we talk about pain management, because this modulation part gives us an opportunity to play around with a lot of neurotransmitters which either increase or decrease the pain. Impact of unrelieved pain, of course. What will happen if a pain is unrelieved? There will be increased rates of depression, pain will not be effectively managed, there will be job loss, reduced responsibilities, negative impact on relationships, and overall reduced quality of life. So, like we discussed when we were discussing the 4 dimensions of pain, also, these are the consequences of unrelieved pain. So, we can discuss the consequences of unrelieved pain in various situations. For example, if in a post-surgical setting, if a patient's pain is unrelieved, then they will be bed bound. They will not be able to walk around. There will be delayed mobilization. There will be delayed recovery because of that. Then it can lead to all kinds of complications. They can be pulmonary complications. Patients can develop deep vein thrombosis and all those things. So that is what happens because of unrelieved pain. In case of chronic pain conditions, if they are not treated, if a patient has headaches which you've not been able to treat, or if they have arthritis related pain, chronic back pain, in the long run, there will be impaired quality of life, and that can lead to depression, that can lead to all kind of psychological consequences. It has a negative impact on relationships, on jobs, and everything. So we have already discussed this previously. So this slide is here again to emphasize the impact that it has. So it is important to realize that it can cost as much as even cardiovascular or disease or cancer, and twice as much as depression. That is the impact if you don't treat the pain properly. Coming to pain assessment tools. So, as medical practitioners, I'm very sure if this were an interactive session, this is a question from me actually for the rest of the audience for later Q&A session, that I want to know that in how many of their clinics or in how many of their healthcare setups do they actually keep this pain assessment tool? Because I want to show you something at this point. So in our hospital, we have a pain measurement card. Okay. So as you know, first if I explain on the slide, the scale on the top is called as numeric rating scale, which is a scale from 0 to 10, whereby 10 means absolutely unbearable pain and 0 means no pain. So whenever we are assessing pain in our patients and whenever we are trying to assess the severity of pain in our patients, we ask them, can you point on this scale of 0 to 10 how much pain you have? If they have severe pain, they might say 7, 8, 9, 10. If they have moderate pain, they'll say somewhere around 4, 5. And if they have mild bearable pain, they might say 2, 1. Sometimes it's 0 also. Sometimes they have come to you for a completely different problem. They may not have pain at all. So this is a very important pain assessment tool. And this is, I want to show you, I hope everybody can see. This is a pain assessment tool that we have provided in our hospital to all the nurses who are doing vital assessment. So whenever a nurse is checking the vitals, whenever they're checking the vital, if they have to check the temperature, we have to provide them a thermometer. If they have to check the blood pressure, we have to give them a sphygmomanometer or a BP machine. Now, if they have to objectively note pain as a vital sign, we have to give the appropriate tool to them. So this is the tool that we very commonly use in various settings, and not just in theory. To use it, to be able to use it practically, it is my suggestion that you get it printed and give it to your nursing staff and people who are monitoring pain for you, so that it becomes easier to objectify and document this fifth vital sign also. So, like I was showing you, this is one of the pain cards that we have been providing to our staff. Another one is an even more interesting way to do it is that we printed it out in a smaller version. This can be laminated and worn along with your identity card, ID card. So this is the size of that. So again, extremely useful to give to anybody who is monitoring and documenting and assessing pain in whatever setting that you're working in. So this is the importance of tool, because no matter how much you talk about these tools in theory, unless and until you provide it to the person who's doing the assessment on ground level, it cannot be done. Now, these are some other tools, as you can see. VAS or visual analog scale is one of the most commonly used tools in pain assessment, whereby a patient is asked to just point on the line how much pain he has. And there is a very interesting scale down here. This is the Wong-Baker Faces pain rating scale, where you can see the expressions. So this person is smiling, he is very happy, so he has no pain. But as you progressively move forward, this hurts little bit, this hurts little more, this hurts even more, this one hurts a lot, and this one hurts the worst because he's crying. So typically, if an individual is not able to quantify on a scale of 1 to 10 how much pain they're having, then we can show them this faces scale and ask them, how are you feeling? Probably they will be able to pinpoint. This is also a tool which is useful in children and pediatric population, in which they may not be able to rate anything out of 10. So the Wong-Baker Faces scale is useful in the pediatric population to assess the pain scores. Now, talking about a 5-step approach to pain assessment. Of course, self-reporting can be there. We try to assess based on what the patients are feeling on a scale of 1 to 10, whether it is mild, moderate, severe, right? Based on the pathology. So, of course, we have to take previous history. What is the past history of this patient? Have you recently developed this pain, or have you been having it from before also? Do you have any previous history of chronic pain, arthritis? Do you have any history of cancer? Have you undergone a procedure that can cause pain? So, of course, this is all a part of the past history that we need to take to understand the pathology of that pain. Then behaviors. Behaviors means, what are the consequences of that pain? Have you been crying? Have you been yelling? Right? Then caregiver input. Of course, if a patient is in pain, we have to ask their caregiver about their experience of the pain in the patient. Has there been any kind of change in behavior, or has there been any action that can indicate the presence of pain? And then, of course, analgesic trial. So whenever we are taking history, we have to ask, what painkillers have you already taken for it? And after having judged what kind of pathology it is, what painkillers should be employed or should be used at this point of time to further take care of your pain. Two major goals of pain assessment are, of course, assessing the pain burden and assessing the pain mechanism. So we need to know both the things. What is the intensity of pain? What is the burden of pain? How much it is affecting a patient's life? And secondly, what could be the possible mechanism of pain? Because that is going to decide the further management of pain. Now, moving on to pain management. Pain management in itself is sometimes very lightly taken very lightly by a lot of people, but it in itself is a huge topic, and it can be done by a variety of factors. A multi dimensional approach, it can be managed, and we have to look at the non-pharmacological aspects of managing it, and we have to look at the pharmacological aspects of managing pain. So the first slide that we have here is about the non-pharmacological methods. So there are a number of non-pharmacological techniques which can help to relieve or reduce a patient's pain. Very commonly, we use cognitive behavioral therapies. For example, if there is somebody is having a severe pain in their back, but we tell them, okay, try to think about something else, listen to some music, maybe watch a movie. So it does sometimes happens that when they are distracted or when they are thinking about something else, they may forget about their pain. Then hypnosis is a described technique, non-pharmacological imagery is a described technique. There is so much talk about relaxation and yoga and meditation. There's so much talk about breathing techniques which help in shifting your focus from that pain and distracting you so that it helps to reduce the pain. And of course, associated emotional support. Like if you have somebody sensitive around you, it obviously makes handling that pain easier. So these are the various non-pharmacological methods which are often employed in addition to pharmacological methods to help in reduction of pain. Then physical techniques are there, of course. Sometimes just a simple change in position can help to reduce the pain. Massages can help to reduce the pain. Our physiotherapy colleagues, often they are using a heat cold application. They are using so many of their physiotherapy techniques uh, to help in reducing pain. Creating a comfortable environment goes a long way, and it's extremely important to help with activities of daily living, because if a patient is limited in their activities of daily living, no matter the reason of pain, it is going to have bad consequences, because the patient will go into a vicious cycle of being upset because of being in pain, and then being in pain because of being upset. And if something hinders with your activities of daily living, it really bothers the patient. So assistance with that is definitely required. So, like I said, all these non-pharmacological methods, which are now shown in this diagram over here, they do not replace, but they do complement, and they do help in reducing the symptoms, affecting the pain perception, and they assist with relaxation. They even might help with improving sleep of these individuals. And many times, because of pain, the next bigger problem that happens is that, okay, individual is in pain, so he cannot sleep. Now, if he cannot sleep, then the problem, it becomes compounded, because the individual is in pain and he is not well rested, so now he's fatigued also. So it is just adding on to the problems of that individual. Now talking a bit about the pharmacologic therapy for pain. There are a number of medications which are available to tackle or to manage the pain. And just until now, we were discussing, if we have taken the pain history properly, if we have examined the patient properly, then we can decide and judge what painkiller to be prescribed. So, of course, acetaminophen or paracetamol and NSAIDs are usually the first line treatments for most patients with acute, mild to moderate pain. NSAIDs can be anything like an ibuprofen or an aspirin, diclofenac, anything. So that usually is our starting point of managing or trying to treat or reduce any kind of pain. We start with an acetaminophen and NSAID. Among the NSAIDs, of course, we have to keep in mind that the kidney functions of the patient should be normal. And we also have to keep in mind not to keep giving these for a very long period of time. Even when we are giving them, patients should be kept adequately hydrated to protect the kidney. But having said that, among the NSAIDs, ibuprofen remains one of the better ones. It is also available for children. Like if in the pediatric population, if you are asked what NSAID should we choose, it is usually ibuprofen. Then, of course, topical NSAIDs are recommended for low back pain and musculoskeletal injuries. Um, NSAIDs can be of various categories. Non-selective ones, like we mentioned, should be used in caution, especially in renal disease, also in cardiovascular disease, also in a patient with gastrointestinal bleeding, because these agents can cause gastritis and peptic ulceration. Always should be used with an antacid when they are being used. Now, a newer kind of NSAIDs are available, which are selective COX-2 inhibitors, and these, for example, etorecoxib, these do not cause as much gastritis as their other counterparts. Of course, now in addition to these medications, sometimes more often than not, we do have to use adjunctive medication. For example, a muscle relaxant may be additionally required for a back pain, okay, or an adjuvant working in synergy with first-line agents, for example, a caffeine. So these adjunctive medications are very, very important because they add on to the analgesic effect of the prescribed medication, and overall they help in reducing the pain more effectively. For severe pain, treatment has to be escalated to stronger medications like a tramadol or a tapentadol or a even more strong opioid. So that brings me to the WHO pain ladder. Now, for everybody who's sitting here, it's extremely important for all of us to know about the WHO pain ladder. So this was devised by WHO somewhere in the 1980s, and for the last 40 odd years, it has remained the same, whereby they say that this is the stepwise approach that we take when we are managing pain. This was initially described for cancer pain, but now it is also used in a post-operative pain setting or any pain setting for that matter. So, as you can see, there are 3 rungs to this WHO pain ladder: mild pain, mild to moderate, moderate pain, and moderate to severe pain. Typically, in a mild pain, the starting point is a non-opioid plus minus adjuvant therapy. So this non-opioid that they say over here is usually a paracetamol or an NSAID or a paracetamol NSAID combination along with adjuvant therapy. I will talk about adjuvant therapy later. Step 2, mild to moderate pain, is a weak opioid plus minus non-opioid plus minus adjuvant therapy. So as you see, the change that has happened from mild to moderate is that a weak opioid has been added. Okay, and when you go to the severe pain, this weak opioid is substituted by a strong opioid. Plus minus non-opioid plus minus adjuvant still continues. So what are weak opioids? In the country where I practice, the most commonly used weak opioids are tramadol, tapentadol, and buprenorphine. These are the weak opioids. And strong opioids, again, the 2 most common ones which are used are morphine and fentanyl. Non-opioids, like we already discussed, typically paracetamol and NSAID combination. Adjuvants. What adjuvants are we using? These adjuvants are the ones which are going to help with the pain modulation and help in achieving better or superior pain relief. Okay, typical examples, a couple of examples that we already discussed were muscle relaxants, caffeine. Some more I would like to mention are antineuropathic medications like maybe a gabapentin or a pregabalin. Sometimes even steroids have to be used as adjuvant therapy for pain management in situations like, for example, bony metastasis in cancer-related pain. So these are the various adjuvants that can be used. So as you can see, non-opioid remains there in all 3 levels. Plus minus adjuvant therapy remains in all 3 levels. The only thing changing is that no opioid, weak opioid, and strong opioid. So this is a very useful ladder to remember whenever we are titrating or managing or escalating or de-escalating pain medications for our patients. Now, what are the key pillars of pain management? When do we say have we achieved a safe and successful pain management regime? It obviously, whatever we are achieving has to be patient-centered, evidence-based, and consistently applied. So whatever practice we do, it has to be scientific, it has to be evidence-based, and at the center of the therapy should be the patient, and the patient should be relieved of their pain. So what are the things that we look into? It can be scheduled multimodal analgesia, it can be stratified opioid therapy with patient-specific adjustments, and expectant management of chronic pain and medications for opioid use disorder therapies. So these are the various aspects of successful pain management or key pillars of pain management that we can consider. Now coming to a very important concept of multimodal analgesia. So many times when I am teaching or training some staff, I often ask them that consider an example. You have a patient who has come to you. The patient is a case of pancreatic carcinoma now with widespread metastasis even to bones. And the patient is getting paracetamol also, NSAID also, gabapentin also, steroid also, morphine also. Do you think it is correct or do you think it is wrong? More than 99% of the times I get the answer that it is wrong because they are getting too many painkillers. But actually, that is not true. Because when we discuss the pain pathway, there are many receptors along that pathway which are responsible for the transmission of pain. And all these medicines that I just listed are working on all these different receptors. So our job is to act on all these receptors so that in totality we achieve pain relief. And of course, and in totality that we eliminate excessive usage of one single medication. If I don't use a supportive medication, then I may have to use, for example, very high dosages of opioids. And then I will have too many effects of the opioids. So it is always better to, in these kind of scenarios, better, or I could say that many times it is required rather to use more than one agent to achieve optimal analgesia with minimal side effects of each individual agent. So we are achieving effective relief with synergistic action of all these agents. So this is the concept of multimodal analgesia. Another example that we can think about this in a post-operative setting. For example, in a post-operative setting, and I'm talking more about post-operative because I am an anesthetist primarily who's now trained in pain management. So in a post-operative setting, of course, patients might have an epidural catheter in situ. They might be receiving continuous epidural analgesia. In addition to that, they might also be on paracetamol, NSAID, or other adjuvant combination round the clock. So this is correct. It's not that if one modality of pain relief is being used, then the other should not be used. This is the concept of multimodal analgesia. Rather, in addition to these multimodal pharmacological methods that we are using, we should add non-pharmacological techniques also so that a holistic pain management can be achieved. So this is a good, important takeaway from today, that analgesia, more often than not, needs to be multimodal. So now we are back to this diagram. For applying the multimodal strategy in achieving pain relief. So pain pathway, again, transduction, transmission, perception, and modulation. So at various levels, if you go into the details of it, there are so many receptors which are responsible for transmission and modulation of pain. Act on all of them. When you know them, act on all of them. At the periphery, what is happening? There's a source of pain and it's causing a lot of inflammation. Compression will help. Cryotherapy will help. Cryotherapy, like even application of ice helps. So whenever there's injury, we say apply ice. NSAIDs will help to reduce this inflammation. Sometimes local anesthetics also help to reduce the inflammation. Local anesthetics also help in reducing this transmission of pain because they block the sodium channels and they delay the transmission of pain along the nerve fibers. Regional analgesia, again using local anesthetics can reduce this or slow down the transmission of pain. Then opioids can act. Opioids act at the peripheral as well as central level. There are mu receptors and other receptors at various levels of this pain pathway. So opioids work at all those levels. Then gabapentinoids, like we have been discussing, muscle relaxants, like we have been discussing, they are going to interrupt the transmission of pain. And finally, what is going to modulate the perception of pain? As you can see, paracetamol, caffeine, opioids, ketamine, all these act at different receptors. For example, caffeine is acting on adenosine receptors. Opioids are acting on mu receptors, kappa receptors. Ketamine is acting on NMDA receptors, but they're all acting on different receptors of the pain pathway, thereby achieving multimodal analgesia. So, with this, if we come back to our daily practice and if we start thinking again of the various patients who come to our clinics with different kinds of pains, it is often best to treat them with a combination of non-opioid and drugs and analgesic methods to achieve better analgesic effects. If you go through literature, you will also always see that, okay, I have decided to give my patient drug A and drug B and drug C. Now, if these three are available as a combination, it will be easier for the patient to take this medicine because he has to take only one pill. I am able to give all three salts, but the patient has to take only one pill. So, in pharmacology, it has been seen that combining two analgesics or more analgesics is more efficacious. It reduces the adverse effects, offer better pain relief, and provide better compliance because the patient just has to take one tablet. So definitely, if in our practice we are using multimodal analgesia, it's even better to use that multimodal analgesia as is in the least number of tablets that we can. So best to use a combination of analgesics if they are available in your practice. Now, if we are particularly talking about the non-opioids and the most commonly used simple analgesics in practice, for example, if we are using a plain paracetamol or if we are using a combination of ibuprofen and paracetamol, it has been seen in a number of studies that the combination is providing a better and superior pain relief to patients, and they have favorable effects on functionality with lesser side effects. So now, after having listened to this entire lecture and after having listened to all about multimodal analgesia, I'm sure that this does not come as a surprise to anybody now, because we have already established the fact that a multimodal approach is better than just a single targeted strategy with a single agent in order to achieve optimal pain relief. Again, this is a Cochrane study which has, again, for this combination shown that encouraging results are there when compared to single drugs. Now, an interesting, let's learn a little bit more about an interesting adjuvant that is used in these over-the-counter pain medications. So, caffeine. Many of us start our mornings with coffee just to become alert enough to be able to go to office. Now, scientists realize that this caffeine can help with more than that, because this is working on adenosine receptors, and adenosine receptors are a part of the pain modulation pathway, and they realize that caffeine can be used as an adjuvant to achieve better pain relief when acting on the adenosine receptors. So, as this graph shows that if you combine analgesic with caffeine, it is shown to have faster and stronger pain relief. And it is a non-habit forming adjuvant, so a very interesting additive as can be added to various pain relief formulations, right? So what is the rationale of using and combining caffeine? Because it positively influences the bioavailability of paracetamol and NSAID and enhance the analgesic effect. And it also reduces the pain, subjective perception of pain, because like I said, it is acting on the adenosine receptors in the pain modulation pathway, and Additionally, it can help to boost the brain activity, can induce a little bit more alertness in patients, and thereby help them in performing activities which they are otherwise not able to do. Otherwise, they may be a little dull because of their pain. So it will help them to overcome that dullness and perform their functional uh, and operate better functionally in their daily life. So that's the rationale of using and adding caffeine in various formulations. So since a long time, combination of paracetamol and caffeine or of NSAID plus caffeine have shown superior results. Caffeine in combination with ibuprofen also has been established to give superior results in situations like a dysmenorrhea or postoperative pain relief or dental extraction and these kind of situations. Now, another instance where caffeine works very well is headaches, particularly post-dural puncture headaches. So, for those of you who are familiar, if somebody undergoes any surgery under spinal, a subarachnoid block or a spinal anesthesia, and if there is too much CSF leakage, then because of that, patients can develop post-dural puncture headache. So that is also one scenario where formulations and combinations containing caffeine uh, help to reduce the vasodilatation in the head and thereby decrease headaches. So caffeine containing agents or formulations help to reduce headaches. Uh, Now coming to the importance of interprofessional teams in pain management. Okay, so up till now we were discussing that we have, I think, concluded without doubt that there are multiple receptors and multiple methods of reducing the pain, and there are multiple dimensions of pain that need to be reduced. So it is never it cannot be a tunneled approach by a single individual. It has to be a more holistic approach, and it has to involve contribution from a lot of health professionals. It can be a doctor, a nurse, a pharmacist, a clinical officer, occupational therapist, physical therapist, so many patients, so many people. And in this diagram on the right, you see that, of course, as for any other disease, even in pain, the patient is the center and everything else is working around the patient. So many things: medicines, physical occupational therapy, dietitian, nutritionist, social work, allied health professions, biomedical sciences, pharmacy, nurses, everybody. Because everybody, all of these professionals look at pain from a different angle. And once they are able to more holistically understand the pain, they are usually able to holistically manage it and at the end of the day provide the most optimal pain relief. And this is the best practice approach for pain management for any of the patients who are suffering from any kind of chronic pain. So that almost brings us to the end of this session with a few important take-home messages that pain and the related disabilities remain a major social and therapeutic problem that has been established beyond doubt. Acute pain, if it is short-lived, it can be considered a warning sign, but if it is not treated on time, it can become chronic in nature. Analog scale, visual analog scale, if I show it to you again, these kind of scale, this is the gold standard tool in pain assessment, and it is my urgent, or not urgent, but it is my sincere request to all of you to start incorporating this tool in your routine practice. Then, although several analgesics are available, focus should be on the use of non-opioid analgesics. So, I am at the moment, I am speaking from Southeast Asia, I'm speaking from India, and I'm speaking to esteemed doctors of Africa. And if you go further west in the United States, they are dealing with a different kind of problem where they have prescribed narcotics too much. They have prescribed too much of opioid analgesia, and now they're dealing with the problems of addiction and tolerance and dependence. So they are on the other end of the spectrum. But of course, it's a lesson for the rest of us to avoid opioid analgesics in routine practice. So if not opioids, then what? We still have a whole gamut of pain medication that we can use. Another important thing is that multimodal analgesia using two or more drugs and techniques that target different sites of pain, it reduces the chances of central sensitization and avoid the detrimental effects of opioid overuse. So I think we have established again beyond doubt that it is always better and a superior method to use multimodal analgesia rather than a single agent analgesia. There is good evidence that if you combine two analgesics in a single tablet, they provide better pain relief and they have better acceptance and tolerance by patients. And ideal or optimum patient care for pain patients involves interprofessional approach. So these are the very important take-home messages from today. I hope that I have been, thank you, I hope that I have been able to sensitize you all to this very, very important but often under-diagnosed and under-managed problem of pain. And thank you. Thank you. I think over to you, Doctor.
Thank you so much, ma'am. You almost covered most of the important dimensions of the pain. Though briefly, I can understand it's quite a vast topic, but there are many areas, right, which you have touched upon, and you have made this very complex science. You have put it in most simple way. Thank you so much for that. So now let me take the questions on behalf of our audience. So what I have done, I have tried to filter up the questions, right? And I'm picking up the questions that are not covered during the discussion. So let's start with Q&A part of the session. And the first question is related to the current climatic conditions. We can see cold wave is going on in most of the parts of the world, and I guess first question comes from that thought, that how do we treat pain in the joints due to cold weather?
Okay, so since the problem starts with the weather, the first tip is keep yourself warm, because it has been seen clinically and it has been established scientifically that cold typically worsens all kinds of pains, especially those related to arthritis or musculoskeletal pains. So the most important thing is protect yourself from that cold, keep yourself warm, wear enough clothes, and keep stay in a heated environment. Still, if you are suffering from the pain, then hot packs are often useful. So hot water bottles or hot packs or whatever you have, it's a very useful non-pharmacological method of reducing symptomatically your pain and comforting you. Having said that, as I said, in the winter season, typically these pains are known to increase. Sometimes for short periods of time, say about even for up to 2 to 3 weeks regularly, you may need to take painkillers, over-the-counter painkillers, or painkillers advised by your doctor. They may need to be taken. And my only suggestion or advice is that people are very afraid of using too many painkillers, but I feel that you should not avoid going and buying over the counter. But if your doctor is advising that you can take something regularly for 2 to 3 weeks, I'm sure you can. Don't wait for the pain to reach there and then start taking the painkiller. If it has started, the earlier you solve the problem, the earlier you start taking medication, the earlier your pain will be solved. It will be relieved.
Right. And as you have briefly mentioned about hot bags, hot water bags, maybe, or heat therapy, other than winter, in case of pain management, one of the non-pharmacological approach is using this kind of hot water bags. So,
Yes.
and what we have seen, doctor, like even like personally, when I travel to Western side or even to Africa, there is mixed approach when it comes to such kind of non-pharmacological approaches. On Western side, they are also recommending for the ice packs or cold therapy. When we go towards Asian sides, it is more of hot bags. So, what is the right approach in your opinion?
See, uh, ice packs or cold packs work best in the first 72 hours. Okay. So this is what I have learned and I have seen and I have been taught that if you have acute injury, or if you have say if you have sprained your ankle or something like that, or if you have developed a spasm in the muscle, then sometimes ice packs, they work better, but they work better in the first 72 hours. If your pain is continuing longer than that, then generally heat application is a more useful method of reducing pain. Still, a lot of physiotherapy setups, they use alternate ice and heat techniques also, right? So that's how they are managing the situations. But typically, in my opinion, in a setting less than within 72 hours of injury, and having said injury, I think ice packs work a little better then. That's all.
All right. Thank you so much. And let's move on to next question. That uh, what could be the best approach for the management of pain in case of pregnancy in pregnant women?
Very important and valid question. Because in pregnancy, very often we have seen a wide variety of pain conditions in pregnant ladies, starting from back pains because of the change in the curvature of the spine and the gravid uterus coming on, to sometimes because of water retention in pregnancy. Sometimes ladies can also suffer from carpal tunnel syndrome. They have wrist pain. So there's a wide variety of pains which can happen in pregnancy. And the problem is that in pregnancy, not many painkillers can be taken. So to start with, I will say that if you are pregnant and if you are in pain, it is better to utilize non-pharmacological methods of pain relief and topical measures of pain relief. So, if you are having some back pain, it is better to go for uh, hot packs or massages, or maybe topical NSAID gels to take care of your pain. If still you're not getting relief, then the safest medicine that you can take is a paracetamol. So, the safest medicine in pregnancy, the safest painkiller in pregnancy is paracetamol. So you can take paracetamol. Uh, Even doses up to 4 grams a day are safe. So that should be your first go-to tablet. But even if that is not working, then we usually do have to resort taking to NSAIDs, but or a combination of PCM and NSAIDs. But remember that if you are in that kind of severe pain which is requiring NSAIDs, then they are strictly to be avoided in the first 3 months. It is out of question in the first 3 months to use those NSAIDs because they might interfere with fetal formation. They are also preferably avoided towards term and the end of pregnancy because uh, they the NSAIDs can interfere with the closure of the ductus arteriosus in the fetus. So these two extremes, first trimester strictly avoid NSAID, and towards the end and the last trimester also strictly avoid NSAID. In between, if you are in between in the mid pregnancy period, you can even take NSAIDs under a doctor supervision with proper guidance.
Right.
So that's how it is.
Right. And you have touched upon, rather you started with the different categories of pain, right? And you have shown based on different components how pain is categorized.
Mm.
So next question is related to how to differentiate uh, on the basis of signs and symptoms between neurological and regular or nociceptive pain.
Thank you for that question. Very relevant question. And I think I didn't cover it properly while I was taking the lecture, but very important question. So, the classification that we have based on the nature of pain, we classify it as nociceptive versus neuropathic. Nociceptive pain is usually a aching kind of pain, or there's some aching sensation involved, or stretching kind of pain, or a very vague pain that the patients are experiencing. So this is nociceptive pain. Neuropathic pain, on the other hand, will have features like burning. It can have tingling. It can have electric shock like sensations. It can have, patients can say that we feel that ants are crawling in that distribution of pain. Sometimes that neuropathic pain can be so severe that even if a cloth touches that area, or even if the wind touches that area, it can induce or incite the pain. So these kind of situations, they usually fall under neuropathic pain. A very classical example of neuropathic pain would be something called as post-herpetic neuralgia, if you have seen it in your clinical setups, or a trigeminal neuralgia. So these are the kind of typically neuropathic pains which are seen in our practice.
Right.
I hope
And
I was able to clarify. Yeah.
right. And ma'am, like they are also, I hope they are getting on the basis of the triggers or the causation.
Sorry.
Neuro, are they also getting differentiated on the basis of the triggers or the causes?
Yes.
Neuropathic and
So, yes. So what I just told you are the clinical presentations of nociceptive versus neuropathic pain. The causes of nociceptive pain are, it can be either, for example, a trauma, or it can be a visceral pain which is coming from the viscera inside because of stretching of the visceral organs or disturbance over there. So those are usually the kind of pains which fall under nociceptive category. Whereas in neuropathic pains, usually there is involvement of the nerves in some way or the other. Either they are infiltrated, or they have been cut, or they are damaged. That is why they are leading to pain. Now, for example, another example of neuropathic pain can be a diabetic neuropathy,
yeah,
in which because of diabetes, the peripheral nerves have been affected, their blood supply has been affected, and they are dying nerves, and they are calling for help in the form of neuropathic pain. So, yeah.
right. So since we are talking about neuropathic pain, I will pick up the next question, which is related to neuropathy. Uh, our audience would like to know which is the most preferred treatment for sciatica.
Okay. Uh, okay. So, sciatica, first of all, uh, there are many mimickers of sciatica. So, be sure that what you are talking about is sciatica. If you are having any pain which is starting from the spine and going into your leg, it is not necessary that it is sciatica. So, the first step is that you go to your doctor and get yourself evaluated. If they feel the need to get an MRI of the spine done, they might even get that done, so that a proper imaging can be done, and the cause of pain or the source of pain can be uh, identified for sure as a nerve compression by the intervertebral disc. So the first step is getting the correct diagnosis. Why I'm saying many conditions mimic sciatica is that sometimes even simple muscular pains can mimic it. Okay, so the first step is get it diagnosed properly. Now, the second step, suppose it has been established as a radicular pain or a sciatica pain happening because some disc in the spine has moved from its place, and it is now causing compression on the nerve. So the second thing that we always think about is what is the duration of sciatica, because usually initially, uh, just with the help of regular pain medications and with the help of physiotherapy, um, these kind of pains can be managed. Okay. If they are going on beyond, say, 4 to 6 weeks, but still the patients are not getting relief in pain, then we even offer epidural steroids to these patients. So, as a pain physician, many times under the guidance of fluoroscopy, we are giving epidural steroid injections to these patients to take care in managing the pain of sciatica. Now, if still the pain is continuing and it is not getting relieved, despite taking medication, despite undergoing physiotherapy, despite even taking epidural steroid injections, then in rare circumstances, you might require surgery. But very few cases of sciatica actually end up requiring surgery. Most of them will resolve by all these other methods that I just said. Okay. Uh, so that's about sciatica. But the important thing to remember is that if you have any even slightest hint of any motor weakness in your limb, that means that if you have any kind of muscular weakness in your limb, then you must immediately consult a surgeon directly, because that is when early surgery is indicated.
Right.
I
Right.
hope I hope
Thanks
that
for
was
that.
clear.
Yeah, absolutely. Absolutely. It's quite elaborated, ma'am. Thank you so much. And our next question looks quite interesting, that uh, could deficiency of electrolytes lead to pain or chronic type of pains?
Deficiency of electrolytes. I will not call it deficiency of electrolytes. I might call it an imbalance kind of thing of
Yeah.
electrolytes. Yes, sometimes they can cause muscle cramps, but not chronic pain.
Okay.
Usually
And
not
how,
chronic pain.
right, ma'am,
Yes.
and how to address that?
How to address that? See, if a patient comes to us with pain, electrolytes is not the first thing that we usually think of as an etiological factor for causing that pain. If your electrolytes are not as they should be in homeostasis, then there's something else which is wrong in your body. So something else is going on. Okay, but having said that, if sometimes, for example, after extensive workouts or something, you might feel that you're having cramps or something. I personally feel that the best way of handling that is to just keep yourself hydrated properly, drink enough water. In an Indian setting, sometimes so Dr. Rahul would know, we make shikanji and we drink that. So like it's a combination of some salt, some sugar, some lemon in water. That kind of drinks. So electrolyte rich drinks you can take. But I think that that's about it. And that usually is not the primary etiology that we look for in chronic pain situations.
Right. And I will take last maybe couple of questions now, ma'am. So, what efforts can be adopted to to ease access to pain medications?
Could you repeat that? There was some interference.
Yeah. What efforts can be adopted to get easy access to pain medications?
To get easy access to pain medications. Okay. Uh, it's a double-edged sword,
Mhm. Yeah.
because it's important. While it is important to have some pain medications available over the counter, it is also important to for the patients to take them under supervision, so that they know what correct dosages they are to be taken in. But I think for patients who are suffering from chronic pain, they are educated enough and they know well enough when to use what. So I think if we are disseminating enough information material to them, even over the counter medications often are useful. Now, if you're asking me how to make those medications more easily available to public, I think there are a lot of policy making decisions which would be involved at the level of the government to decide which medications are strictly prescription based and which medications may be allowed over the counter. So I don't think I can give an expert comment at the moment regarding the situation in your country. But yeah, those changes come at policy making level from the government.
Right, ma'am. Yeah. Now
Yeah.
I will move on to yeah, sorry, please go on.
Sorry for interrupting, but since we were talking about availability of pain medication, for example, uh, opioids like morphine and fentanyl are under strict regulations in India. Uh, so the government has taken many steps to make sure that they don't fall into the wrong hands. So for medications like these, of course, more stricter and more stringent action is required, and more what do you say? Uh,
We-
more
Regulations, maybe.
things are in place. Yes, it is a little more difficult for the patients to get them,
True.
especially narcotics. But for the other medications, at least they should be prescription based. Otherwise, over the counter medications can sometimes be uh, used wrongly also.
Right. Got it. Thank you so much. And now I will move on to the last question, which is there are many questions asked by our audiences on that area of multimodal analgesia. You have covered it very nicely, ma'am, but please allow me to ask just one question, right?
Yeah.
As a representative question from this group of questions,
Yes.
that do you find it necessary to use more than two analgesics for acute pain management, maybe of mild, moderate, or severe categories?
See, it depends. It depends what is the severity of the pain in an acute setting. If the patient says that my NRS or my visual analog scale, my VAS scale is just 1 or 2, then sometimes even a plain paracetamol may act. But always go back and think about the etiology of the pain. If you have any suspicion of any inflammation happening anywhere, then have a lower threshold for prescribing an anti-inflammatory, NSAID.
Right.
That is the important thing to consider. So it's not about whether we are using single agent or double agent or triple agent. It's about the more important thing is to identify and or try to identify the etiology of that acute pain, and try to think that okay, maybe could there be some inflammation involved, and if there is, then it is always better to give a PCM and an NSAID combination or an adjuvant along with it rather than a plain PCM, because paracetamol alone cannot reduce the inflammation. So I think to answer your question, go back to the pathology and then decide.
Right. Thank you. Thank you so much, ma'am, once again for this wonderful session and for taking each and every question and responding them in quite in detail. It is quite insightful. And I would also like to thank our wonderful audience, right, who keeps on, who they ensure that they tune in to our webinars on a regular basis. I hope you have put in your suggestions as well as your feedback in the box provided. You can even suggest us the topics for our future webinars, right, and we will certainly consider them. uh, Thanks, and I would like to convey thanks to our professional societies and bodies for partnering with us by providing CME and CPD accreditation. Thanks. Thank you once again.